Anorexia nervosa is the first eating disorder that we're going to be really digging into and looking at. And the three points that I have on the slide are the three diagnostic criteria for anorexia. The first diagnostic criteria has a lot to do with the body weight. And what's really nice about this is that previously, anorexia nervosa, the diagnosis of it relied on BMI, which isn't, it's a great way to say how underweight a person is, but it's not really a reflection of their illness. And so now what we have is BMI, we can use that as a severity specifier for the disorder, but it's not part of the diagnostic criteria, which means we can diagnose more people and we can start treating more people. We can get insurance authorization for more people. It's more inclusive. So we're excited about that change. So the first criteria, restriction of energy intake relative to requirements, leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. So what this looks like in the real world to kind of, make it more tangible, is a person who maybe looks like they're dieting sometimes, like, oh, I'm not eating sweets. It may look like a person who is cutting large food groups out of their diet, like, oh, I don't eat bread anymore, or I don't do dairy, or I'm a vegetarian, or I'm a vegan, or I eat raw food, or I'm a non-GMO, or whatever it is. And what you'll find over time, what we observe with our patients, is that left unchecked, you can have a person who had a very normal range of food, and over time, the foods that they allow themselves to eat narrow and narrow and narrow and become less and less until they're left with just a few foods that they feel comfortable with. And usually, the foods they feel comfortable with have very few calories in it, very little fat, very little protein, no carbs most of the time. And so it's a dead end, really, from a nutritional perspective. So we've restricted our energy intakes. My body is taking in less than it needs. The body is having to turn on its own tissues for energy. So it begins to break down the muscles. The heart's a muscle. Body doesn't discriminate when it's starving, unfortunately. And so we have a significantly low body weight in these contexts. The thing I want to add, because I know you all work with adolescents a lot, for an adolescent, developmental trajectory is incredibly important, and a lot of pediatricians miss this. When you have an adolescent, they should never lose weight. If they're obese and they're on a plan to lose weight with their doctor, that's kind of a different thing. But if you have a typically developing child who's been between the 25th and the 75th percentiles their whole life, and all of a sudden I take them for their 13-year checkup and they weigh something, and I take them for their 14-year checkup and they weigh the exact same thing that they weighed when they were 13, that's a problem. It's a problem because they failed to gain as expected. If you look at the growth chart trajectories, between the ages of 2 and 20, we're always gaining weight, pretty much, for the most part. Our line goes up. Even if I'm not getting taller, my body transitions from an adolescent body to an adult body. I fill out. It's our bodies change, we gain weight, and that's normal. And so for adolescents, as they're growing, failure to gain as expected is the same as weight loss. And sometimes you go into your pediatrician and you see the chart on the wall and it's like, well, they're still in the green zone, so it's okay. But what you need to really be aware of as clinicians, as parents, family members, is to be aware of what your child's trajectory was or your patient's trajectory was over the course of their life. Because everybody's unique. This is one of the things that our dietitians battle with constantly, is trying to undo what the pediatrician said or what the doctor said. My doctor said I wasn't underweight. Well, technically, no, your BMI is still in a healthy range, but for you, for your body, for your history, you're underweight. And so, when you see a general chart, if you Google it, right, you'll have a range of numbers this big, a range of weight that you can be in that's okay, that's this big. And what we find at ERC is that our patients' weight range is usually about 5 pounds. They can be between X weight and X weight, 5 pounds different, and that's where they need to stay. There's very little room for fluctuation. There's not room for being 10 or 15 pounds below that. Because that's, and we'll talk about this moving forward, but that's when the eating disorder can get its hooks in. I've personally had a patient who has a very narrow window for her ideal body weight range as set by our dietitians. And she can drop 5 pounds below that and be completely back into her eating disorder mind. So for our patients, for eating disorder patients, staying within a very defined weight range is critically important to the maintenance of their recovery. The second criteria for anorexia is an intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain, even though at a significantly low weight. And these things aren't mutually exclusive necessarily. I can think of many patients off the top of my head who have both of these things present at the same time. There's the intense fear of gaining weight or becoming fat. So you take that first criteria that you have up there, right? They're already at a significantly low body weight. Anybody with eyeballs can look at them and say, this person is too thin. Or look at their growth chart and say, you're not where you need to be. And then you add the second criteria on top of it. And this is where things start getting interesting. Because you have a person who has the intense and passionate belief that they are not underweight. And because they have, and this kind of ties into letter C also, but because that belief is back there in their head, we can try to we'll take them to an outpatient dietitian. A lot of parents try this first, and we'll get them on a meal plan, but they won't gain anything. But they should be gaining a pound a week, and they're not, and it doesn't make sense. The numbers aren't adding up. I have an IOP patient who was slowly dropping weight, and she had been really stable for a long time, and then her weight kept creeping down, and then we finally found out she was ditching her lunch at school. And so there's interference that with the ability to gain weight back to a healthy place that comes from the belief that I'm already too fat, I'm already overweight, I need to lose more weight, and I'm terrified. I'm terrified of gaining weight. When our patients at ERC start weight restoration, it is a hard day because that's when they have to kind of sit down and face themselves and, drink or eat whatever it is that they know is intended to make them gain weight. It's a really challenging process. And it's hard to achieve in an outpatient level of care. We find that, you can ask our head dietitian and she would say that she's not ever had a successful experience weight restoring anyone at lower than a PHP level of care. Because the eating disorder, everything about the eating disorder is designed to fight against it, to fight against weight restoration, to fight against gaining weight. And so without really a lot of containment and pretty strict boundaries, it's just hard to do. It's logistically hard to do without someone being with that child or that adolescent or that adult all the time for every meal before and after. The third diagnostic criteria for anorexia is the disturbance in the way in which one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or persistent lack of recognition of the seriousness of the current low body weight. So kind of like what we were talking about before, we have this person who's very underweight, who is fighting to not gain weight, who's terrified of becoming fat, and who already feels like they're there. Even though, like we said, everyone knows that they're underweight, the doctors, the dietitians, everyone's saying, this is a problem, this is an issue. And you can have this person with an eating disorder sitting there and saying, no, I don't believe you, I don't trust you. You're trying to make me fat. You're trying to make me gain more weight. I need to lose weight. I'm 20 pounds from my weight goal. You know, these are the types of things that you'll hear. There's this very rigid, inflexible resistance because this person with the eating disorder is so convicted, so passionately convicted that what they see in the mirror is true. And what they see in the mirror is extremely different from what the rest of us see when we look at them. And so it's this very interesting experience where you're working with this person whose reality doesn't match up with yours, you know? And, you know, we have this area of weight, body, food. Most of our patients are rocket science smart. They're brilliant. They're competent, they're straight A students, they're involved in everything, they're good friends, they're successful, and they can be completely in touch with reality in every area of their life, except when it comes to this. And it kind of throws you for a loop in the beginning, because you're like, okay, wait, we were just talking about school and everything made a lot of sense, and now we've changed gears and nothing is clicking. So we have to be aware that just because our patients are so competent in other areas of their life does not mean that they are competent in this one. And that's a hard dialectic to balance. It's hard for me to remember sometimes because there's an ability to kind of present as not as ill as they actually are, which is a lot of times how the eating disorder is able to hide for a long time and to get quite severe is because they're able to maintain their functioning in all these other areas really effectively. The last phrase in letter C, I just want to mention, this is a really interesting quality. Persistent lack of recognition of the seriousness of the current low body weight. There's almost a quality of apathy that our patients have, kind of a dismissal of concern, like, it's not really that bad. I don't know what everyone's freaking out about, kind of a phrase, right? I'm fine, everything's fine. There's a minimization. And so I think it's really important in the treatment of our patients, that we talk about the fact that the eating disorder has this quality built into it as a self-protective factor. This is how the eating disorder is, it kind of hides. It slips under the radar. It hides in the shadows. It convinces the person with the disorder that it's not that big of a deal, which is pretty ingenious if you think about it, right? It's a parasitic kind of a process, and it convinces the person with the eating disorder to do everything in their power to keep it, and to keep it safe, and to keep it alive, and to limit intervention, and to limit help from others, and to not tell the truth. And so it's this very interesting world that's created by the eating disorder for the patient. A lot of patients feel that the eating disorder is a friend, quite close to them, and so there's almost a grieving experience that they have once we start treatment and they begin separating their identity from that of the eating disorder.